committee for giving me a chance to present our experience of endoscopy therapy for anastomotic leak. No conflict of interest. Among the several anastomotic complications after aspidectomy, leak is the most common and serious, and the incidence was 3% to 25%. The incidence of anastomotic leak is higher in the cervical anastomosis than in the intrathoracic anastomosis. Esophageal anastomotic leak following aspidectomy is associated with 3 times higher death risk than for patients without anastomotic leak. Prolonged spillover of gastric or esophageal contents, including digestive enzyme and bile and bacteria into the mediastinum, combined with constant mediastinal movement with respiration and negative intrathoracic pressure, sucking the contents outward, which contribute to the high mortality rate. The treatment of anastomotic leak remains controversial as the indication for surgical, conservative, and endoscopy therapy is remain not non-standardized. The 2 predominant therapeutic options include primary surgical intervention and curved stent insertion. Immediate detection and prompt sealing the leak are of importance to prevent further damage. In addition, draining any correction at the anastomosis is necessary to control infection. In a systemic review, endoscopic stent insertion for management of anastomotic leak was successful in 72% of patients. However, overall mortality was 15%. The average time for stenting is 6 to 8 weeks. Stent-related complications occurred in 34% of patients, which include migration, bleeding, perforation, and tissue ingrowth. In general, endoscopic stenting is limited to the leaks involving less than 30% of the anastomotic circumference and without extensive necrosis of gastric conduit. Taken together, stenting for the esophageal anastomotic leak is potentially beneficial but not without potential risk. New alternative method, endoscopic vacuum-assisted closure, consists of endoscopic insertion of the sponge into the cavity induced by leak, and followed by application of controlled continuous lateral pressure around 100 mm mercury. The vacuum removed wound secretion and reduced edema, and therefore improved blood flow, and the use of the sponge led to the formation of granulation tissue. This results in a clean wound base and improved subsequent wound closure. I'll show you the procedure. After assessing the leak about the size and location, Levin tube inserted via nose and brought out through the mouth. Sponge is sutured to the tip of the tube and inserted into the cavity using grasping forceps. When cavity size is fully reduced with granulation tissue, endoscopic vacuum treatment could discontinue. After cutting the distal part of tube, leaving 1 or 2 holes, polyurethane sponge is sutured to the tip of the tube. Trimming of sponge is required according to the size of the cavity. The sponge size is needed to be smaller than the wound cavity to promote collapse. I'll show you 2 cases. After Ivory's operation for esophageal cancer, anastomotic leak was developed. Even leak persists after even 19 days conservative management, and so endoscopic therapy was applied. through the wall defect, we can see the 2 centimeter size wound, 2 or 3 centimeter size of the cavity was noticed. After introducing sponge into the stomach using aggressive forceps, it can be inserted into the wound cavity using forceps. So when the opening of the cavity size is small, it is difficult to insert the sponge into the cavity, but the endoscopy vacuum treatment is more effective when the opening size is small. Lastly, it should be checked whether the tube is twisted in the oral cavity. Okay. 11 days after treatment, significantly reduced cavity size with the development of granulation tissue inside was noticed and therapy was finished. The sponge was exchanged twice for effective drain and stimulation of granulation tissue without adhesion between sponge and cavity during therapy. Another case, 5 days after ivory's operation, anastomosis was detected endoscopically, and 3 days later, endoscopic vacuum treatment was applied. Just below the anastomosis, about 1 centimeter size small wound cavity was noticed. Because the size of the cavity opening was small, only 4 days after treatment, wound cavity significantly reduced with granular tissue growth. So therefore, no more vacuum therapy was necessary in this case. As you can see here, when the granulation tissue developed and the cavity size was significantly reduced, the cavity usually fully reduced in in a month. In a German retrospective study, outcomes of patients who were treated with stent or endoscopic vacuum treatment for intrathoracic leak were compared. As you can see, the overall success rate was significantly higher in the endoscopic vacuum treatment group than in the stent group. The endoscopic vacuum treatment was successful in 85%. In addition, the less stricture developed in the endoscopic vacuum treatment group than in the stent group. Listen, another German retrospective study analyzed 45 patients with anastomotic leak following a spasectomy who received either vacuum treatment or stent treatment. As you can see here, 7 patients from stent group were switched to the vacuum and 4 to the surgery. According to the initial therapy, the success rate was higher in the endoscopic vacuum treatment group than in the stent group. When classified by final therapy, the success rate was also higher in the vacuum treatment group than in the stent group without marginal statistical significance. Therefore, endoscopic vacuum treatment could be more effective than stenting for treating intrathoracic anastomotic leak. Lastly, I will show you our experience. Using a more homogeneous group of patients with anastomotic leak after spasectomy for esophageal cancer, we tried to evaluate the efficacy and safety of endoscopic vacuum treatment, and we also tried to identify factors associated with treatment failure and treatment duration. We analyzed the initial 20 cases performed in the Samsung Medical Center between October 2016 and December 2017. Endoscopic vacuum treatment started at median 3 days after leak, and the median duration of endoscopic vacuum treatment was 14.5 days, and the median number of required intervention was 5. The successful rate was 95%, but one case with a large cavity large size rig was unsuccessful with treatment with endoscopic therapy and died. As you can see, after endoscopic treatment, the structure was developed in 35%. Because we have only one treatment failure case, so we could not identify the prognostic factor associated with the failure. Instead, we investigated the factors associated with the long duration of endoscopic treatment. As you can see here, the longer endoscopic vacuum treatment was required in patients who received neoadjuvant treatment. And in addition, the size of opening of cavity was also associated with the long treatment duration with minor statistical significance. I will summarize and conclude my today's presentation. Endoscopic vacuum assisted closed treatment is effective for post-operative anastomotic ring after esophagectomy for esophageal cancer. Nonetheless, longer treatment duration may be required for patients who receive neoadjuvant treatment and have large leakage opening. Therefore, early detection and prompt treatment could improve the clinical outcomes of those patients. Thank you for your attention.
Thank you. Thank you for your nice presentation. Okay.
Congratulations on your nice talk. Repeated sponge change may be required in some patients. So how can you determine the interval of the repeated intervention for large fistulas?
Yes, that's a good question. We usually perform the vacuum change twice weekly because if we have to resize the sponge to more effectively reduce the size of cavity. So, and during the exchange, we can re-evaluate the status of the rig. So, if the rig is not improved even using vacuum therapy, we have to change it to another stretch. And if the change is not significant, we can make a decision to discontinue the treatment. So routinely, twice weekly change is necessary.
So this technique is can be applied to stomach or colon fistulas?
Yeah, recently I saw some papers in the colectomy cases. So, but I do not have any experience, but I also have experience in the fistula after gastrectomy case. But it is a little, it's not less effective than the esophageal leak because in case of leak after gastrectomy, the subtotal after gastrectomy, the length of the tube is longer than the esophageal, so it could be redundant. So it is very difficult to fix the sponge in the proper place. But after total gastrectomy, and then it could be effective. Thank you.
Okay. So one question, we have a time limit. It's the last comments. Yeah.
Congratulations, it's very interesting. I also work in a cancer center. It looks very effective. But my question is that what is the material sponge? Is it a special material or we can use any type of sponge?
Yes. The polyurethane sponge with about 200 micrometer size, the micropore. It is widely used for some vacuum treatment. Actually, vacuum treatment is widely used for wound infection or pressure sore, but we just apply this technique into the endoscopic area, so we can easily obtain the material. Yeah, so like include sponge.
Thank you.
Okay, endoscopic vacuum therapy is such as a salvage technique. But maybe you can usually use the esophageal leak, but some endoscopists also try to duodenum or other region. Success rate is low, but we have another option to treat this region. Okay, thank you.